Welcome to Module 2 of Philosophical and Scientific Foundations for Nursing Practice. In this module, what we're going to do is we are going to talk a little bit about some things we touched on last week, or last module, and we're going to build on them. So the first one is the idea of population. So last time we mentioned that a population is a group of patients, typically, or a group of people that are joined together by some common thing. Now, what we need to do when we talk about researching a population is we have to formally define it. So let's say that we said our population of interest is ICU patients. So how are you going to know which people you're going to include in your study and which people you're going to exclude from your study? So you might say, okay, well, obviously it's ICU patients, so therefore it's got to be a patient in the ICU. So now, are you interested in every patient who's in the ICU or only some of them? Are you interested, say, perhaps only in adults? Well, what is the concept of adult? How do we find that? So perhaps it's 18 to 65. And what you're thinking all of a sudden is, well, wait a minute. Aren't people who are 66 or 67 adults? And the answer is yes, they are adults, but they're also classified as elderly adults. So are you including the elderly adults in your study? Now, sometimes you'll see a study that talks about elderly adults as a population of interest. And so what you're thinking to yourself is, well, maybe that's going to be 65 and up. And what you find is that the study only measures people from 65 to 85. And you're thinking, well, wait a minute, how come there's people not in there above 85? And well, the answer is people who are above 85 are sometimes referred to as the very old. So when you read a study that talks about ICU patients, or adult ICU patients, you need to know what age ranges are they including in that study. You might have one study that includes patients from 18 all the way to 110. And you might have another one that goes from age 18 through 65. And another one that goes from age 18 to age 85. And you might have another one that starts at age 25 instead of 18. Well, could there be a meaningful difference in the outcomes among those different studies? And there's no one answer to that question. That's a question you have to answer as, number one, if you design a study, and then number two, as you're critiquing a study that's already been done. So, some other examples of things that you might need to think about. So let's go back to our example we were using from Module 1, urinary tract infection in ICU patients. Now, if they already had a urinary tract infection at the time of admission, are we going to want to include that patient in our study? Well, if we want to know is, does this Foley versus that Foley impact urinary tract infection? Then if they already had one, they're not going to be a good fit for our study. So we are going to exclude patients who already had a UTI. Now, another question we might want to ask is, do we want to exclude patients who were transferred from another unit to the ICU? And there might be reasons why you would want to, and there might be reasons why you wouldn't want to. What you have to do is ask, is it appropriate in this study, in this context? So sometimes it will be, and sometimes it won't be. And if you're the person designing the study, you have to make that decision. And you need to back up your rationale. And if you are reading study that's already been done, what you have to ask yourself is, was that appropriate? And if it's not appropriate, how might it affect the findings of this particular study? So, other things that are often excluded would be patients who are immunosuppressed. Sometimes women of childbearing age are excluded from studies, especially drug trials, because when a woman becomes pregnant, she has to drop out of the trial. But the problem is, are you expecting a woman of childbearing age to take this drug? Well, if you are, maybe you should be studying that drug in a woman of childbearing age. So it's not so simple as what's convenient, but also what's meaningful. So the process of taking this concept of a population of interest, patients in the ICU, and then defining it specifically with inclusion and exclusion criteria is called operationalization. So when you operationalize the population of interest, you're taking it from this abstract concept in your head and you're putting it down on paper to a list of standards or criteria that you can apply to an individual person in front of you. So when you do your research critique, one of the things that I'm going to ask you is, what is the population of interest? And you're going to say, well, it's ICU patients. And then the next thing I'm going to ask is, well, what is the operationalized population of interest? So what you're going to do is you're going to look for inclusion-exclusion criteria, and a nice study will say the inclusion-exclusion criteria were. Sometimes they don't tell you up front, but they kind of describe it. Or sometimes they don't tell you at all. And if they don't tell you at all, what you're going to have to do is say, well, they didn't really define how they operationalized it, so I just have to guess. So you're going to say, here's the population of interest, ICU patients. Here's the operationalized population of interest. A patient in the ICU who did not have, who was either admitted to the ICU or transferred to the ICU, who had a Foley, who did not have a UTI at the time of admission or the time of transfer, who was not immunosuppressed. And then you're going to say, okay, that's the operationalized population of interest. Is it appropriate? So when we ask you the population of interest, there's really three aspects. What's the broad concept, conceptually speaking, ICU patients? 2, what were the inclusion-exclusion criteria that defines or operationalizes that population of interest? And then 3, is it appropriate? So all three of those things have to form part of your analysis of the population of interest. All right, study factors. Now, study factors, remember we said there's 2 types of factors. Ones we're interested in and ones we're not. The ones that we are interested in are called study factors. And you can have more than one factor. So for example, you might be interested to know, does this new Foley versus the old Foley affect UTI? And does this new hygiene technique improve or change UTI, yes or no? So in that case, you would have 2 study factors. You might be interested in, say, if you're having a question about staffing ratios, you might want to know how does the ratio affect patient outcomes, and how does the percentage of experienced nurses, as defined by nurses who have more than 5 years experience, affect patient outcomes. And you also might want to know, how does educational level of the nurse impact patient outcomes? So in that case, you got 3 different study factors, one being staffing ratio, one being the level of experience of the nurses, and the third being the education level of nurses. Now, factors can be broken out into 2 broad categories. They're either going to be qualitative or quantitative. So a qualitative would be something like gender, male or female, or education, bachelor's degree, associate degree, baccalaureate degree. Or it could be quantitative, which would be something like the number of years on the job, 1, 2, 3, 4, 5. The ratio of faculty nurses would be quantitative. So study factors are going to be either quantitative or qualitative. And it doesn't matter whether it's an extraneous factor or a study factor, it's still going to be exactly the same thing, quantitative or qualitative. So when you're reading a research article, you're going to want to compile a list of the study factors. So you're going to have the study factors are this, this, and this. Those are the ones they're interested in. Extraneous factors, and there's a whole bunch of those. A lot of times demographic things are extraneous. So for example, age, gender, education level, those would all be extraneous factors most of the time. A lot of times what you'll see in a study is you'll see a table of demographic data, and what they're showing is that demographically speaking, the 2 groups that they're studying are similar. And what they're trying to say is none of these demographic things are extraneous. That are extraneous variables are confounding variables, because the 2 groups that we're studying are pretty similar with those extraneous factors. So that is study factors. All right, let's talk about response variables. Now, this is a little bit more complicated than talking about the population of interest or study factors. Response variables have a number of different classifications, and there's a lot of ways that they can be combined, and studies can have more than one response variable. So just be aware that when you see response variables, it can be a little bit complicated. So if at first what you're seeing doesn't make sense, it is okay to ask for help. What you don't want to do is just, I'm just going to do my best, which means do terrible. Don't do that. Ask for help before you turn in your assignment. In order to do that, that means you need to be doing your assignment ahead of time. Crazy concept, I know. Now, you lose points for turning in things late. You don't necessarily get bonus points for turning them early, but you know what you do get is peace of mind. And you also get the ability to ask for help before you turn it in. So, highly recommended. All right, so response variables, there's three basic categories of response variable. So I'm just going to list them first, and then we're going to go over them in a little bit more detail. So the first response variable type is called nominal. Now the word nominal comes from the Latin word for name. So like nombre. So nominal means we're going to name categories. Another way of saying nominal is categorical. Now, the next one is ordinal, which is also categorical, except there's a difference. In this case, you can put the categories into a rank order. So, some examples of ordinal would be high, medium, and low. There's an obvious order to those categories. So, the key distinguishing difference between nominal and ordinal is nominal, there is no obvious or objective order. Now, sometimes a person might go, well, I like this better than that, but if it's open to interpretation or if it's subjective where someone else could go, yeah, but that one is better than that one, then it's not ordinal. It is going to be nominal. So nominal is categorical where you can't put them in a rank order. Ordinal is where you can put them in a rank order. See, ordinal order, or put ordinal in order. So, high, medium, low, hottest, medium, warm, cold, coldest. That would be ordinal. And then the last one is numerical. And in numerical, there's two subcategories, but we're going to ignore one of them, and we're just going to say continuous. So continuous variables are numerical, where there is not necessarily a discrete numbering, but there could be any number of variables. Now, as an example, age is not, we can express age as a discrete number, 10 years old. But is a person actually 10 years old? Well, actually, if you take the day they were born, and then you take the moment, this moment right now, there actually is a certain number of seconds, and even nanoseconds. And you can measure that as narrowly as you like, or you can measure it a little bit less precisely and come up with just an age in years. But a person who was born in January, who is 25, is a very different person from a person who was born in August, who is also 25. Does that make sense? So even though you can give it a round number, if you were measuring it more precisely, you could there's an infinite number of possible measurements you could measure. So that's the idea behind continuous. So now let's talk about each of those, most biological data is continuous. Heart rate, blood pressure, height, weight, BMI, blood alcohol level, white blood cell count, complete blood count, all those sorts of things are continuous variables. All right, so now let's go back and let's talk about nominal, ordinal, and numerical in just a little bit more detail. All right, I lied. We're not going to talk about them in more detail. We're actually just going to talk about the parameter or statistic. Now, we need to understand the difference between a parameter and a statistic just for later on. So we might as well introduce the concept here. So let's say for a moment that we want to know what is the average weight of a nurse on the unit. Well, if you measured all of the nurses on the unit and took their weight and averaged them together, you would have the true average weight, and that would be called the parameter. Now, a nursing unit is a relatively small thing, and it's possible to actually collect every single one of those people and calculate the average parameter in this case. But if what you do instead is you take a sampling of the nurses on the unit. You don't measure them all, you measure a sample, and then you calculate the average of that sample. That's called a statistic. So the purpose of the statistic is to estimate the parameter. So the parameter is the underlying true thing, and the statistic is what we calculate based on our sample size, on our sample that we've collected in our study. So the parameter and the statistic will be described by the same words, but they refer to different things that are being measured. So in one case, it's the true thing that if you could measure them all, you'd get it. And the other is what you're calculating on your sample. So in the case of nominal variables, the parameter or the statistic is the proportion of people who fall into that category compared to the whole. So let's say we're talking about cause of death. In the state of Florida, there are 17 causes of death, 17 categories. Now, in keeping with the idea that you can't put them in a rank order, dead is dead, and if you die from a heart attack versus from cancer, you are no more dead than anyone else. So we can't put those in a rank order. You can't say, well, being dead by cancer is being worse dead than being dead by car accident. They're both dead. So there's no obvious order to them. And so what we're going to do is we're going to calculate the number of people, the proportion of people in one category against the total number of people dead. And that would be called the mortality for that particular cause of death. So what is the mortality of heart attacks? In Florida, you take all the number of people who died from a heart attack, and then you divide that by the total number of people who died, and you get the proportion of people who died from a heart attack. So that would be your parameter or statistic. Now, some nominal variables are what we call binomial. And what that means is there's only two choices. So in the case of dead, there's only two choices, dead or alive. Kind of like Bon Jovi. So either dead or alive, those are your only possibilities. So if you know the percentage of people who are dead, then you know the percentage of people who are not dead. So if the percentage of people who died during the study was 5%, what is the percentage of people who did not die during the study? Well, it's 95%. So in a binomial response variable, there's really only one statistic because you implicitly know the other side. In a case where there's multiple categories, like in the case of category of death, there's 17 causes of death. Well, if you would have to know 16 of them before you knew the 17th. So that's a little something special that goes with binary response variables. Now, let's talk about ordinal variables. Ordinal variables are special in that they can be rank ordered. So they can be treated a little bit like numbers, but not. Now, what's interesting is that you can actually put numbers on the ranks, but those numbers are arbitrary, and the only thing that matters is the direction, not the magnitude. So if you put your categories and you said, say, 1, 3, 7, 10, 100. Well, 100 is not 100 times bigger than 10, it's just the next category up. Does that make sense? It's the number of categories and the direction that you're going one way or the other that's important, not how far you've traveled in the other direction. There's a number of ways that you can measure ordinal responses. Some of them are arbitrary, and some of them take numerical data and then turn it into ordinal data. So an example of this would be quartiles. So if you take 100% of the data, I'm going to come over to the board for a second. So if you take 100% of your data and you break it up into half, and then each of those half into half, what you end up with is the bottom 25%, then the bottom 50%, the bottom 75%, and the bottom 100%. So this would be called the first quartile, the second quartile, the third, and the fourth. So you're taking numerical data and you're breaking it up into quartiles. Now another thing that you could do with this is instead of breaking it up into 4, you could break it up into 5s. So you probably guessed what this is going to be called, and it's going to be called quintiles. So we would have the first 20%, then 40%, 60%, 80%, and 100%. So this would be the first, second, third, fourth, and fifth quintiles. If you break it up into groups of 10%, then it would be deciles. And if you broke it up into groups of 1% each, then you would get percentiles. So if you the way you interpret a percentile, so for those of you who ever took the GRE or the ACT or the SAT, and you got a score like say 60th percentile, what that means is you scored better than 60% of the other people. So what we've done in this case is we've taken numerical data and turned it into ordinal data. A very common form of collecting ordinal data is called a likert scale. So you've probably taken these dozens of times in school where you get a survey that says, rate the following each on the following scale. Strongly disagree, disagree, neutral, agree, and strongly agree. That would be a likert scale. Sometimes instead of having those words, they'll say on a scale from 1 to 5, where 1 is strongly disagree and 5 is strongly agree, how would you rate this? Still a likert scale. Now, what you can do with a survey that has a whole bunch of questions is you can sum up the results of those surveys, and then you can treat that score as a numerical value. So in this case, you're taking a bunch of either nominal or ordinal questions, summing them together to come up with a number, and then treating that number as a numerical response variable. And that is called a summed scale. And actually, you are extremely familiar with this concept because it's how tests are constructed in school. So let's think about this for a moment. You had a 50-question test that was multiple choice. So you had 4 options, and 3 of the options were wrong, and 1 of them was right. So on each individual question, you had a binomial right or wrong. And then we counted up the number of rights, and then we divided that by the total, and we came up with your grade, expressed as a percentage correct. And then we treated that as a number. Now, how was that number calculated? It was calculated by asking you a whole bunch of nominal questions that were either right or wrong. Pretty crazy, isn't it? Now, in healthcare, there's a number of summed scales that are very, very commonly used. So, for example, the Hamilton D depression score. It's 17 yes-no questions. You sum up the number of yeses, and the more yeses you get, the more likely a person is to be depressed. Another example would be the Glasgow Coma Scale. And so there are 3 questions in this, and there's multiple, one of them is like, it's like a score of 1 to 5. Another one is a scale of like 1 to 3. And so you add all those up and you get a scale. Now the interesting thing is the lowest score you can get on a Glasgow Coma Scale is 3, because the lowest score you can score each one of those categories is 1. So if you take 1 and you add 1, 1, 1, what you get is 3. You'd be interested to know that a large number of nurses report a Glasgow Coma Scale of 0. That doesn't mean the patient is extra dead. It means your nurse is extra ignorant of how the Glasgow Coma Scale works. Occasionally physicians will do that too, and well, that's even sadder because you would expect that well, they've got a lot more schooling than a nurse does, so they should really know their stuff. But hey, that's just how the cookie crumbles. So that is how we do summed scales. Another example of a summed scale would be the APGAR score for labor and delivery. Now, when it comes to ordinal in particular, a lot of times ordinal data is reported or interpreted from subjective data. An example of that would be a sleep study. So in a sleep study, you've got these little waves and you've got these things that happen, and then you've got some person who has to decide, is this a meaningful event or is this a not meaningful event? And so anytime you're doing that sort of observation, and it's not just for numeric or for ordinal data, but really any kind of data that requires observation and then interpretation of results, there's going to be a certain amount of error that creeps in because there's subjectivity in the grading or in the scoring. So a lot of times what we'll do is, let's say that a person is reading MRI reports. And so they are looking at MRIs and they're deciding if it's abnormal or normal, or if the patient has cancer or not cancer, or whatever it is that we're studying in this case. What we're going to do is say they've got 20 of them that they have to record. At the end of the 20, we're going to randomly select 3 ones that they've already done. And we're going to ask them to rescore them again. And what we're going to see is how closely did they rate them the same versus different. If they rated the same one exactly the same all 3 times, that's going to be perfect for what's called intrarater reliability. So intrarater is how often does the same person rate the same case. Does that make sense? So if I read your essay today and I gave you a grade, and then I read your essay again a week later, did I give you the same grade or did I give you a different grade? So the consistency with which a rater can repeat their own performance is called intrarater reliability. There's another thing you can do. What if it's not just one person interpreting the data? What if it's multiple people who are interpreting the data? In that case, what you're going to do is you're going to have all of the different people who interpret the data interpret some of the same cases. So let's say that there's 100 cases and we have 5 radiologists reading these MRI reports. So each one is going to rate 20 individually. But we're going to select, say, 3 or 5 of them that everyone is going to rate together. They're not going to sit in the room and do it together, but each of them will do the same case. And that way we can see how different are the different raters, or how similar the different raters are. And if the differences between them are very, very close, we call that intrarater reliability. Interrater reliability. So how similar do different raters perform on the same case? That's interrater. How similarly does the same person do on the same case? That's intrarater. And these are really, really important concepts. Now, the last concept we're going to look at before we move on to continuous is the idea of validity. We've already talked about reliability. We've already talked about reliability in the context of some external rater, and those intra and inter-rater reliability. Now, what we're going to do is we're going to talk about the reliability of a questionnaire. So let's say if I asked you 3 questions, or better yet, let's say that you're in a job interview, and they say, use 3 words to describe yourself. And you say, I am energetic, I am peppy, and I am outgoing. Now, have you actually described 3 different things about yourself, or have you described the same thing about yourself in 3 different ways? If I ask you 3 different questions, how are you today? How are you doing today? And how are you feeling today? Have I asked you 3 different questions, or have I asked you 1 question in 3 different ways? So, anytime you're asking a questionnaire or constructing a questionnaire that has multiple questions on it, to some degree, you're going to be asking questions that are somewhat similar. So the degree to which answers correlate with one another is a measure of reliability. Now, the measure of reliability in this case we're going to call Cronbach alpha. If your Cronbach alpha is too low, it means that your questionnaire is not very meaningful because the answers are so different that it's kind of, we're not even sure what you're asking. If your answers are too similar, it's that you're asking basically the same question over and over again. Does that make sense? So you want, just like Goldilocks, you want your Cronbach alpha to be not too high and not too low, but just right. So that's the idea of Cronbach alpha. So reliability is the idea that when you measure something, are you measuring it consistently? And there's a couple measures of consistency. One is within a survey, Cronbach alpha. Another is within the rater doing it themselves, Intrarater. And the third is among different raters, Interrater reliability. So reliability is the ability to consistently measure the same or similar. The next concept there is validity. Now remember when we first introduced the idea of a response variable, we said that a response variable is a concept and how the concept is measured. So one of the things we have to ask ourselves is the way that we're measuring it a valid measurement of that concept? So if you're talking about the concept of stress, what are some ways that you could measure stress? Well, one way you could measure stress is you can just ask people, do you feel stressed? Well, is that a good measure of stress or not? Is that a valid measure? Another way to do it would be to do a questionnaire that asks, have any of the following events occurred in your life in the last 6 months? And you count up the number of what are considered stressful events. That could be another way of doing it. Another way of doing it would be to measure their pupillary response. Because when a person has a sympathetic response, their pupils dilate. So you can measure the amount of pupillary response. Another way you could do it is by measuring skin conductance. Another way you could do it is by measuring cortisol levels. Now, if you measure cortisol levels, one of the important things is that they change throughout the time of the day. So if you're going to be measuring them, are you measuring them at the right time of the day to have a meaningful measurement? So all of those ideas go into the validity of a measurement. So our concept was stress, and there's a dozen different ways to measure stress. And even within one very physiological way, say cortisol levels, you can measure that multiple ways. So, and then multiple times of the day, you're going to find different things. So it's really, really important that we have valid measurements, because otherwise you might have a very reliable measurement. You get the same number every time. It's very reliable, it's very consistent, but it's utterly meaningless. Well, how is that helpful for anyone? Now, the concept of validity is much, much harder to establish than reliability. Reliability is relatively simple, although sometimes hard. It's a relatively simple thing to understand and sometimes accomplish. But validity is much, much trickier. So at this point, we're just going to kind of leave it at that, the validity. We're not going to go any deeper than that. Now, as far as statistics go, with ordinal data, the main statistic that is used is going to be the median, which is the middle number. So how many people are below and how many people are above? So remember, we're rank ordering. So in rank ordering, the important thing is the distribution of the ranks. So what is the median is going to be the most important parameter or statistic for ordinal data. And now let's talk a little bit more detail about the last response variable, which is continuous. Now in continuous, you've got numbers, and those numbers are going to form a distribution. Now a lot of times that distribution is going to be a normal distribution, sometimes referred to by its shape as a bell curve. Now an important thing to know is that in nature, not everything is a normal distribution. Sometimes you can have different distributions. You can have a skewed one direction or the other direction, or you could have what's called a bimodal distribution. So remember, mode means the most common occurrence. So in this case, this is the most common and this is the most common. Over here, the mode would be right there. The mode is one of what's called a measure of central tendency. Now, one of the interesting things is that when you take random samples, what tends to happen is that no matter what the underlying distribution, your random sample tends to produce a normal distribution. So anyway, as far as your main statistic and parameter go with continuous things, it's going to be the standard deviation and the mean or average. So in this case, this would be our mean, and then the standard deviation is a measure of variance. So the mean is what we call central tendency. So where do our measurements tend to be collected? They tend to be collected here, but there's also a spread, and so that is a measure of variance. And the variance measure that we're going to use in this case is called standard deviation. All right. There are a number of other measures of central tendency, such as median and mode. We have actually described those already in the context of other things. But the most important one is going to be the mean, or the average. And then as far as the measurements of the spread, there are some others, such as variance itself. But the one we're going to be using for continuous variables is the standard deviation. Now, when it comes to designing a research study, you've got to decide what your response variable is. So if you're studying something that is inherently nominal, then that's okay, it's nominal. But if you are measuring something that is inherently numerical or continuous, the best thing you can do is actually measure the continuous and record that variable. You can always categorize it later, but if you just record the category, you can never go back and put it back into the numerical. So as an example, blood pressure. Blood pressure, you can record the number, or you could record something like low, optimal, elevated, hypertension 1, hypertension 2. Now the problem with those ordinal categories is that they've changed over time. Those categories didn't exist up until 2017 with the new American Heart Association, American College of Cardiology guidelines. Up until that time before then, it was low, optimal, pre-hypertension, hypertension 1, hypertension 2. Now you'll notice that there was hypertension 1 and hypertension 2 present in both of those different classification schemes. However, the numbers that defined hypertension 1 and hypertension 2 are very different in those schemes. So even though the names are the same, the numbers they represent is different. So the bottom line is, if you record the number, you can always reclassify it anytime you want. But if all you write down is a classification, you're stuck at a specific moment in time, and you can never go back the other direction.